procedures, we're going to talk about stain removal and biofilm removal. So basically, when patients don't have stain, we need to do biofilm removal only. So when we're removing subgingival biofilm, the approach to that is you could remove subgingival biofilm with an explorer, with a curette, with power-driven instruments, with air polishing, with glycine. All those approaches can remove biofilm subgingivally. Supragingivally, you can remove it with a toothbrush and floss. You could remove it with power-driven. You can remove it with air polishing. So basically, what we're doing is thinking about what the patient has and what's the best way to remove their biofilm. And you want to think about it separately, the best approach for sub and supra. So when patients don't have stain, you don't really need to motor polish, which is really for extrinsic stain only. It's more abrasive than what you need. After debridement, after you've removed all the clinically detectable calculus, we do a final supragingival removal, and you can do that with the toothbrush and floss. And sometimes just to make it, taste a little better, you can use a mouth rinse that might be appropriate for your patient. And you're going to put the chair down in the same position that you would do your scaling and instrumentation. So the patient's lying back in a supine position. Many times you will use the suction if the patient can tolerate it in the corner of the mouth, the slow speed suction. And you will brush the way that you've been explaining to your patient how to do it, floss. Then you will check your work with disclosing agent, make sure you've removed all the biofilm, and then touch up any areas if you've missed any. And you could pick up a curette, an explorer, or the brush, whatever is the easiest to remove any residual biofilm. And then you disclose, and at Middlesex, you'll request an instructor to check when you're seeing outside patients, and then that is checked before you do the last step, which is usually fluoride. So, like I said, there are several stain removal methods. You could use hand instruments, power, motor, and air polishing for stain removal. So we're really trying to figure out what is the best for each patient. So indications for motor polishing are extrinsic stain, so basically stain that can be removed. And as we know, stain is basically an aesthetic issue. And we also could motor polish or air polish prior to sealants. Sometimes pit and fissures will stain, and it's always nice if you can remove any stain that's present and get those nice and clean prior to sealants. And you could air polish or motor polish prior. If you're going to use a motor polish or a brush for the occlusals, you'll have to use the right pumice for that. So because we only motor polish for extrinsic stain, there's a term that kind of describes this technique, and we call it selective polishing. And that means that we select the patient that needs polishing, will select the tooth surface and select the surface that needs to be polished. So not every surface needs motor polishing, not every tooth, and certainly not every patient. So motor polishing can be abrasive, so that's why we don't want to do it when we don't need to. So we're trying to remove extrinsic stain and conserve tooth structure. So procedures for stain removal. So you're going to do complete debridement, remove all the clinically detectable calculus, and you would have treatment planned if you thought the patient was appropriate for selective motor polishing. And many times you'll need to explain maybe why the patient doesn't need it to the patient, because sometimes patients in the past have received that when they didn't need it. So sometimes you just need to explain the current philosophy of motor polishing, and then most patients will be fine with it. So you're going to get a handpiece and latex. There are latex-free cups in clinic, and there's all different sorts of combinations with hand pieces, angles, disposable, sterilizable hand pieces, and every office will probably have a different setup. We tend to use the rubber cup on all surfaces, and then on occlusal surfaces, the brush with the bristles can be very more helpful getting stain out of those occlusals, but we only use those on occlusal surfaces, pit and fissures. So then you're going to select the least amount of abrasive agent. So you want to think about, if you have light stain, you don't want to use heavy pumice, so you'll use a lighter. So that pick the appropriate agent, then you'll scoop it up in a little cup. And same thing, the patient's lying down, you can use your slow speed suction to help suction your patient. And then you just dab on the Prophy paste on the areas that you've selected that you're going to do. And then you just do a few teeth, and you tend to kind of do maybe a quadrant at a time. If the patient isn't tolerating the Prophy paste, you might, rinse by quadrant, or sometimes patients are fine. You could go through the whole mouth. So you just want to assess how your patient's doing. You're going to have a fulcrum while you do this. It may be extra oral. It doesn't need to be super, super close to the area you're working on. You're just trying to balance your work. The harder part when you're first learning how to motor polish is keeping a steady pressure on the rheostat, and you don't want to be too heavy on the foot pedal. Just try and maintain it. And basically you're using intermittent pressure with the cup. It's going on and off the tooth, and short patting motion. And when you're going into proximal, you have to kind of flare the cup so that it will go around the line angles and try and get into proximal. That's probably the hardest part. And again, we're just using a light patting motion. And then when you're done, you're going to rinse, and then you'll suction, and then you're going to floss to remove the interproximal biofilm. And then you will do the same thing. You'll disclose, dry the teeth, use disclosing agent to evaluate your biofilm and stain removal. And then respond as necessary, same thing. You may pick up the motor cup, you may pick up a curette, respond appropriately. And then we always do a fluoride treatment because you are removing the outer layer of the enamel. So you want to make sure and remineralize it and make the tooth structure stronger after you've motor polished. So here's an example of different equipment. On the bottom are the different types of Prophy paste. We usually use unit doses. And there's many different kinds of cups, disposable angles, motor pieces, different angles. The one on the right is the current type we're using in the clinic now, which is like an RDH handpiece. There are cordless types, like on the right, where you just have to charge the handpiece, which can be nice. It doesn't have drag with the cord. So I'm sure you will find all different kinds. And this is just showing you retraction. Many times, like I said, I use the saliva ejector. You could use your mirror, whichever works. And here you can see how they're just flaring the cup, and you do a light on and off motion. Again, same thing. So some of the tricky areas tend to be the lingual of the mandible. So you just have to kind of get the tongue out of the way to access the area. But I think you'll find it's pretty straightforward. And sorry about that. I will get you back. And here are a few more images. This one I like on the left because you can see the cup rotating to the distal, how you really have to angle back and flare the cup. So that's a nice picture of how we have to rotate the cup to adapt. And a few more pictures just showing you how to do it. And then you always want to follow up with the appropriate type of fluoride for your patient. Here's the brush that I was talking about, the brush attachment, which is great for pits and fissures and occlusal stain. So if your patient only had occlusals, then you would just use occlusal extrinsic stain. You could just use the brush and do those areas, and then toothbrush floss the rest of the mouth for the supra-gingival biofilm. So sometimes that's exactly what this slide is saying. Sometimes we'll do a combination where a patient might have extrinsic stain, just a few areas. So you remove the stain and then you can toothbrush floss for the rest of the mouth. So basically slow speed hand pieces that we use, only the dentist uses high speed, which can actually cut the tooth structure used with a burr. So we're not using those, we're using slow speeds. And on our unit, since they're, that's the one that we use, our slow speed. So slow is defined between 6,000 and 10,000 RPMs. So principles of abrasives. So one thing you want to think about is basically the more particles that you use, the faster abrasion rate is going to happen, okay? And if you use a dry powder like pumice, that's going to have a faster rate of abrasion. So that's why the pumice, the Prophy paste generally has a little moisture to it to help with abrasion. So the speed. So if you take the Prophy cup and apply it to the tooth and gun it on the rheostat, the foot pedal that accesses the handpiece, you're going to have a faster rate of abrasion. So that's why we maintain a slow speed. Pressure. So the more you apply pressure, the more you'll abrade the tooth surface. So same thing. If you really press down hard on the cup, you're going to abrade more, quicker and faster than you would with light. So that's why we use light pressure. And of course, the contact time. If you're on there for a second versus 3 minutes, you'll abrade more. So I had mentioned you want to select the right Prophy paste. So grit selection generally comes in fine, medium, coarse, and plus. So use the appropriate one for your patient. And there are many different categories of Prophy paste. Most of them will have fluoride. Some do contain gluten, so if your patient has an allergy or sensitivity, you want to make sure and double check that. Some have hydrogen peroxide for more whitening potential. Some are better for sensitivity, which can be really nice if your patient has any kind of sensitivity. And then some have remineralizing properties, which is nice as well. So you want to think about what your patient needs and use the best paste for them. So clinical effects of motor polishing. So basically you can remove tooth structure. So with 30 seconds with pumice paste, you can remove 4 microns of enamel. And then you'll remove more if you're on a demineralized portion of the tooth. So the outermost layer has the greatest amount of fluoride of the tooth structure itself. So when you're motor polishing, you're removing the best part of the tooth, basically, the most fluoride rich. So the concentration of fluoride drops quickly as you go towards the pulp on the tooth. So if the surface layer is polished away, the protection is diminished for the tooth. So abrasives by their nature, they create deep irregular scratches in the tooth structure and restorations. And basically when you motor polish or create these scratches, you actually create a niche to pick up more stain. So it can be very cyclic. So people that really don't like stain sometimes don't realize that the more we motor polish, the more we're scratching the tooth structure, making it more possible to pick up stain. You can definitely, over time, ruin restorations. You can, motor polishing ruins the glaze on porcelain restorations, ruins the composites. So basically, people pay a lot of money for their dental work, so they really don't want to be paying for hygiene services that is damaging that work. Motor polishing, it produces heat with excessive pressure and tends to bother pulps of children's teeth, which can be more sensitive. So you need to be careful with that. So here, I know these pictures aren't super great, little blurry, but if you take a look at the image on the far right, it's like a smooth surface. So this is a composite surface, and in the other two pictures, this is after they've had motor polishing. So it actually ruins the integrity of the outside layer of composites. So you want to avoid motor polishing composites. So contraindications for polishing: no extrinsic stain. If the patient doesn't need it, we don't do it. Patients with caries are at high risk. If we're removing the most fluoride-rich layer, it's not serving the patient well to be doing this service when they are already at risk for caries. And that's the same reason for the xerostomic patient. Patients that have dentinal sensitivity, it's also not a great idea. Newly erupted teeth, not fully mineralized teeth. Primary teeth. Primary teeth have large pulps, which increase the chances of pulpal necrosis, so we tend to avoid those. Demineralized areas, because you'll have a rapid rate of abrasion on those areas. All the restorative that I've mentioned. So basically, sound, healthy teeth with extrinsic stain is those surfaces are fine, and everything else, there's really no reason to do it. Another contraindication for motor polishing is significant gingival inflammation. This is a good example of that in this picture. So when the tissues are inflamed or aggravated, there's no need, because the Prophy paste and polishing actually can delay healing, and it's not helpful. So if a patient is in the middle of scaling and it's going to take you multiple appointments, you'll want to treat the patient and then bring them back for a re-eval, and then hopefully the tissues have resolved and there's less inflammation, and then you could do the stain removal at that point, and that would be a better situation for your patient. So some potential effects on the gingiva: it can be traumatizing to gingival tissues. Certainly the more inflamed, the more of an issue. If you put your rubber cup on the tissue, you're going to remove the tissue. It can cause patient discomfort, and the pumice sometimes is an irritation source for the tissue. And like I said, it can delay periodontal wound healing. So here's an example of some inflammation caused by inappropriate motor polishing. And here's an example of an allergic reaction to Prophy paste. So whenever we motor polish, it creates a bacteremia. So if someone needs to be pre-medicated, they'd have to be pre-medicated for motor polishing. It also creates an aerosol and tends to create a lot of spatter with the Prophy paste.